It's a broad topic. And we're going to first, I know that we're mostly non-clinicians in this room. And so I want to build a foundation of how I think about and explain PTSD, and then we'll launch into this, the project proper. This one over.
Recording.
Yeah.
Okay, great.
There we go. So I don't have any disclosures at this time. If you know a way that I can get a disclosure, please let me know. And I know that we just did the introduction. So like I said, my name is Greg Muller. I'm an assistant professor, licensed psychologist here at the University of Texas. And I did all my training at the University of Florida. And one of the things that we do really well at Florida is our work treating anxiety and OCD. I was part of the intensive outpatient program there, helping to coordinate services for patients during my undergraduate and into grad school. And part of the reason that I was picked up by the University of Texas was my experience using exposure-based principles for the treatments of these conditions. And at Del Med, in our psychiatry department, we're working to become a nationally, internationally recognized center for trauma research. And so I built my clinical expertise to include trauma work as well. And tying into the D43 project, I've also recently joined the Society for Military Psychology, and I'm working to build my expertise working with first responders, with veterans, because I really value servicing that population. That's our beautiful medical center. If you haven't already seen it, I recommend taking a stroll east to go check it out. But I have a variety of things I'm involved with, highlighting if you know people that need clinical services. I'm a member of the Adult Psychiatry Clinic and the Trauma Center. We'll talk about that a little bit later in the presentation. But the main highlight for today is our D43 Ukraine project in collaboration with Texas A&M. And so they can't be here today, but I would be remiss if I didn't spotlight my colleagues that started this project. We're going this way. So we have Dr. Lieberson. He was the former department chair in the Department of Psychiatry at Texas A&M. He has over 30 years of experience in the treatment and research of PTSD. He's a former veteran himself. Dr. Tanya Nicholson she's a research assistant professor at Texas A&M right now, and she's worked in a variety of nonprofits. She was part of the team that brought oral morphine to Ukraine. It wasn't there before her work and her team's work. We have Dr. Marcia Ori. She's been involved in the field of aging and public health for over 40 years, and she does the implementation science aspect of this project. And Dr. Gustavo Tafe, combined MD, PhD, and his work has studied the effects of stress and depression. So we're very glad to have these individuals on our team, and I feel very privileged to work with them. And so we're going to do a deep dive today. We're going to go into the conception of this project, how we programmed our workshop, how we supervised and supported our learners after the workshop, and current endeavors that we have. This is a publication off of the Fogarty Center website highlighting this journey if you want more information. And so I want to lead with a question today, which is stress a bad thing? I'm really curious what your thoughts are. Some brave soul.
Sometimes it depends on the result, sometimes stress could be like something that can help you like recover maybe and try to find another way of the solve this problem. So sometimes, yes, we're thinking about it like, oh, it's absolutely bad. But if we're speaking about, like some perspective maybe, or some like results. So it could be another option. It's like my opinion.
Yeah, the outcome of the stress, what it ultimately leads to. Other thoughts related to this?
Absolutely agree. Stress is an absolutely normal thing in our life. It's impossible to live without it. But the thing is just, if you have it, you have to find a healthy way to just, reduce it. Otherwise, if you won't do that, it can lead to depression and
Yeah, if you haven't integrated the stress properly, it can have downstream effects. And I'm always curious to ask this question. This comes often up in my clinical work, because for people that have had a single or repeated traumatic experiences, the answer they give is no, stress is always bad. And they look at me like I'm crazy. Like, why would you even ask me that question? And so much of, and we think of different examples of how stress might present in our life. If we weren't stressed thinking about a job interview, or thinking about a test we might take, we wouldn't prepare for it. Or if we're walking through traffic, I would hope you have a stress response. And so I think just it's a productive conversation to have with clients of, how can we help you have a different relationship with the symptoms you're experiencing. And when we think about PTSD, I think we can back up and talk about the difference between stress and trauma too. So stress can be adaptive. It helps us respond more effectively to our environment. But the way that I define trauma is that it's an event or series of events that's so significant that the person can't integrate or adapt it into their life. And we see a common pattern of symptoms that present that we as clinicians are looking for in our work. So people have intrusive re-experiencing. So they have nightmares back to what happened repeatedly, flashbacks as if it's a movie that's playing out before their eyes of the terrible events, or they have avoidance. That avoidance can be internal or external. So external avoidance, I cannot go near the places, the people, the activities, the objects that reminds me of the event that I went through. And there's also internal experience, efforts to push away thoughts, feelings, memories of the events that have happened to you as well. And then there's a synergy between those two. So we think about substance abuse as an example, people using alcohol, an external mechanism to regulate their inner life. And then we also see alterations in cognitions and moods. So people feel overwhelming internal experiences. They feel overwhelming emotions that distract them from daily life, or they don't feel much of anything. And that also leads to issues, as you might imagine, or changes in their level of reactivity. They say things like, I can't go out in public. I can't be in crowds. I'm constantly triaging for threat and danger, or the opposite. Like I feel nothing. I feel listless and exhausted all the time. And as you might imagine, there's a lot of synergy between PTSD and other disorders like depression or substance use. In terms of prevalence, it's a fairly common disorder, 5% of the US population presenting with PTSD. As you might imagine, in conflict zones, that tends to be much higher. And lifetime prevalence rate with females tending to endorse PTSD more often than males. But especially when I think about the veterans that I work with, I wonder if males want to help seek in the same way, just because they want to be perceived as weak. So I wonder if these might almost be closer to one another. So we're talking about stress, PTSD, and I often show my clients this graphic as a way to get them to think about what recovery looks like to them. This hits at the idea that there's different recovery trajectories that people engage in with PTSD care. So in ideal circumstances, we have highly resilient people. Traumatic event happens, they have a stress response, maybe briefly, but then it just kind of dings off of them and they're not responding to it significantly. Or maybe somebody does have a traumatic experience and they dip, but they undergo a natural recovery process and their functioning is actually much higher. They say things like, I'm so much more grateful for what I have and who I am. I feel like I can engage in life in a new way and I have a new perspective. Many people, they have a traumatic experience, they have what we think of as an acute stress reaction. Their body presents with the symptoms that we were talking about, and then slowly over time they recover. PTSD is referred to as a disorder of failed recovery. People who go on to develop PTSD have stress symptoms, but then they withdraw from life. That avoidance happens. I'm not going to go near those places or those people, and we see this loop that persists that we'll talk about in a little while. And so when we think about that recovery process, avoidance is a huge aspect that we need to take into consideration. I refer to this very boldly as one of the most important ideas in all of psychology. This is one of the most important ideas that I have with my clients when we think about what treatment might look like. And it's related to the idea of experiential avoidance. I often show my clients Wikipedia because I know they have access to it and they can engage with these topics and ideas. And so experiential avoidance, very simply, is the idea that we move away from things that cause us discomfort as a way to cope with them. And we all do these things. It's natural, right? Like I would imagine with the snow that we had recently, you probably had your heater on, you weren't going outside, you were bundling up. That's all a healthy form of avoidance, but avoidance becomes a problem when it's our only strategy or we're using it really rigidly. And I often describe this as the way that we cope. The way that we try and solve our problems is the problem. I'll say that again. The way we try and solve our problems often is the problem. And that's what we think of as a variety of psychopathology. Depression has aspects of avoidance, PTSD, substance abuse, obsessive compulsive disorder. And so a primary conversation that I have with my patients is, how do you have a healthy relationship with avoidance? And how is the way that you're coping and avoiding leading to the symptoms that you're experiencing? And I refer to this as the PTSD loop. And so the traumatic event that happens and people experience a belief shift, two primary belief changes. The world is more dangerous and I am less competent to handle it. And people become very reactive. They have the trauma response that we were talking about before. And this is at play. And so people live their life, they bump into these reminders within daily life, and they have their symptoms flare up, they start dissociating, they experience intense anxiety, and the person avoids. That works temporarily. But the problem is that by avoiding these reasonably safe situations, there's a failure to process the traumatic memories and make sense of them. They don't learn that the situations that they're afraid of are not truly dangerous, and their beliefs persist, these unhelpful beliefs. And it's a loop, goes around and around and around. And so this builds our foundational understanding of what trauma is. And now we lean towards our Ukraine project. And so I know I'm in a room full of experts, but this is a rough timeline that I share, illustrating when Ukraine became independent, leading to the escalation of hostilities from 2015 up into the full-scale invasion in February of 2022. And so we turn towards the topic of combat-related PTSD. And so no surprise, people that are in active conflict zones are at a higher likelihood of developing anxiety, depression, PTSD. And this is observed cross-culturally in modern conflict zones like in Ukraine. This is a graphic from the U.S. Council on Foreign Relations just showing a distribution of major conflict zones around the world on different continents. I think we are uniquely fortunate in the United States to be shielded from what a majority of the world, what they experience. And so now we turn to, okay, so we know what PTSD, how does this present within Ukraine? And so prior to the full-scale invasion between 14 and 21, up to a third of Ukrainians were identified as being active with PTSD. And you can only imagine that after the full-scale invasion, this is likely only scaled dramatically. And millions have been, and even if you don't have PTSD, millions of Ukrainians have been exposed to traumatic experiences. And these experiences, they have plenty of options. So the experience of being conscripted into the military against your will, direct and indirect combat exposure, aerial bombardment, the death of friends, families, communities, loss of your livelihood, being internally displaced or in really significant situations, detention and abuse and torture by security forces. These are who we're working with and who we're trying to help and treat. And we also, we talk about adapting good interventions to these regions, and we step into the idea of PTSD and stigma. There's obviously, it's getting, my sense is that it's getting better in the United States and in the West, but there's still, because my understanding, again, I'm in a room full of experts, but because behavioral health services were used historically in Eastern Europe as an arm of the government to oppress and detain people that were saying things that the government didn't like, there's a lot of hesitation and a reluctance to engage in behavioral health care services. There's a fast no, I don't need that, no, I'm fine. And this is something that the students we've trained are constantly running into, and we're helping them navigate, because if you're seen as weak or crazy, there's a fear that my group will kick me out or that I won't be able to contribute. I'll be seen as broken. And there's also, unfortunately, not only are people resisting treatment, but there's also a shortage of providers too, just based on the level of need. This was taken in Lviv. You go underground in order to move towards the Opera House. And in the bookstore under the ground, they had, I don't know how many of you are familiar with The Body Keeps the Score, but there was a copy of it in Ukrainian, very prominently displayed. And so I take that as a measure of hope that this is becoming more accepted in the culture, and it's more of a topic of conversation. Many of the people we talk to, they're like, I didn't even know that PTSD was a thing before 2014. It just wasn't talked about in our culture. And so Dr. Lieberson and Dr. Nicholson are actually from Ukraine originally. And so when the full-scale invasion escalated in 2022, because of their robust experience treating PTSD and researching trauma, they felt a need to intervene and a need to provide aid. And so they began to formulate the D43 project. This was prior to my involvement. I joined in fall of 23. And so leaning into what the workshop looked like, broadly, our goal is to titrate up the number of providers that are capable of providing evidence-based interventions and build research capacity in Ukraine as well. We want them to be independent. They want to identify clinicians that are going to be good collaborators, give them robust training experiences. We've done online, in person, and stateside in the United States services that we're going to talk about in a little while. And we wanted to give them the best interventions possible so that they could give their clients an opportunity to recover. Our long-term goals are the strengthening of the Ukrainian psychiatric system, building a professional society, which is in the works right now, helping our students have active collaborations. It's not just us leading the projects. We want them to have their own independent research. And what I'm working on right now is working to expand this project to other conflict zones around the world, replicating the model that we're working on in Ukraine. And so we work to give our clients or give our students evidence-based interventions. So we focused on pharmacology, behavioral activation, which is commonly used in the treatment of depression, and prolonged exposure therapy. We'll go into those in a little bit. They successfully acquired funding through a D43 NIH research training grant. And we winnowed it down from 350 applicants to, I believe it was 31 students in our initial workshop. They're multidisciplinary, taken from a variety of agencies, and we're blessed with the gifts that they bring. A primary recruitment criteria was English proficiency because we wanted there to be synergy with our group. We wanted a similar level of engagement. And so it was really funny. So the way that I got brought into the project, I was in my office one day and I was bored, and I'm like, all right, well, let me go and go move around. And so I was talking with a friend when one of our colleagues walked by and said, hey, we need somebody. Somebody at Texas A&M is recruiting for this project. Are you interested? And I immediately said, yes, please sign me up. I want to do this work. And so in October of 2023, we flew to Warsaw. This is crossing from the Warsaw border into Ukraine. And a significant event during this workshop was the Hamas attack in Israel. This was significant because many of our trainers and our students were of Israeli descent. And so it just kind of set the tone and informed the work that we were doing. I had never traveled overseas before. I was blown away. I had never seen anything like this before. And so it was a deeply enriching experience for me. Credit to Dr. Tafet for taking that photo of the Lviv Opera House. And so our workshop content looked at foundational content. We wanted our students, if nothing else, to know this is what PTSD is. This is how you evaluate it. This is how you treat it. We covered the neurobiology of PTSD, the evidence-based interventions, and then Dr. Ori leaned very heavy into implementation research. How can you take this intervention and use it in a way that works with your site and with your patients? And credit, it wasn't just our team. We were blessed with a lot of help from a variety of people and a strong complement to our prolonged exposure team. They were based out of the Strong Start Institute in San Antonio. I highly recommend looking at their group if you're interested in this topic. And so this is our workshop agenda. I bring this up to point out that I was mostly engaged in the prolonged exposure instruction just based on my history at the University of Florida. I helped to coordinate groups and assist with the lectures. And this was a robust workshop. We started at 9:30 and we were going till probably 7:30 at night. So there was an intense level of commitment from our Ukrainian learners to engage in this work. Dr. Lieberson looked at the neurobiology of PTSD, and this just speaks to the development of our understanding of what PTSD and how PTSD shows up in the brain and in the body. Dr. Nicholson focused on the assessment process because we have good interventions for PTSD, but it's really important that we're not wasting people's time. If we're providing intervention, we want it to be with the right patient. And so we walked our students through how to select and administer PTSD diagnostic scales. I'll show you what that looks like in a minute. The CAPS is very often used for research within the space of trauma and PTSD. I use the PCL. I'll show you that in a minute. And we also spoke to the importance of inter-rater reliability. If we're doing good research, the two researchers need to both agree, yes, this is a PTSD patient, so we have a consistent population that we're researching. And so for those of you who aren't a clinician, I thought it was important to show you what that might look like. This is the PCL5. This is what I actively use with my PTSD patients at the University of Texas. And so this is important not only to get a total severity rating for the patients, but also you can find out not just what PTSD, but what does your PTSD looks like? Are you more of an avoider? Are you more of a dissociator? How is PTSD causing interference in your life from not at all to extremely? So let's look at some of the items. Repeated distressing dreams. Are you upset when you're reminded of your experience? Do you have trouble remembering? Do you blame yourself excessively for what happened to you? And then we step into the interventions itself, like I said, which is what I coordinated. We had picked prolonged exposure. Prolonged exposure has been around, I believe, over 50 years. It was developed by Dr. Edna Foa. I think she's at the University of Pennsylvania. A long, well-established intervention for the treatment of PTSD. We know it works. We wanted to start there as a primary intervention. PTSD has three assumptions. I'm sorry, PE has three assumptions: that PTSD results from a failure of natural recovery. There's a pattern of avoidance that maintains the symptoms. Approaching those trauma cues, confronting and overcoming them is essential for healthy recovery. And there's two primary activities: in vivo and imaginal exposure. So let's look at it in vivo first. So this is we call this a fear hierarchy, or a fear list, or a fear ladder. This is a primary activity that I'm doing with my patients. And this is on a hypothetical patient. I took the example of a school shooting, if somebody had developed PTSD after such an incident. And in PE, it's usually 0 to 100, but it's effectively the same scale here. So 1 is, I don't like it, but I can do it. And 10 is the most afraid I've ever been in my entire life. And so let's look at some of those activities. So maybe a 2 is, or a 1 is writing the words gun, shoot, and violence, just looking at them, a really mild exposure. Watching a documentary on school shootings, holding a fake toy gun, reading like an article perhaps in the news about the shooting, up to going to the place where it happens, or visiting the grave of somebody that was lost that you might have known. So these are the in vivo activities, things that the client is doing outside of the session. And then you have the imaginal exposure activities, which are a retelling of the traumatic experience so you can process the memory. So what that looks like is the client sitting on the couch, and I give some kind of prompt like, settle into your seat, get comfortable, close your eyes or soften your gaze, and tell me the story of what happened as if it were happening right now in active tense. Imagine it in your mind as clearly as possible. So you're trying, and then the client tells the story repeatedly over a 20-minute or more time span, helping them engage with the content, process their memory, teach their body that they don't need to be so reactive to this memory, that they can be present mindfully with this memory. So that's prolonged exposure. Dr. Toffet took the pharmacological intervention aspect of this lecture. I'm speaking to what we know works best. We know that there's a good synergy when medications and behavioral practices are used in the treatment of PTSD, cover the mechanisms of action, and how to combine multiple medications for a significant treatment effect. Dr. Ori, like I said, took the implementation aspect. So I'm going to use a silly metaphor. So you can be a great chef or a baker. You can make a beautiful dessert, and then you slide it in front of somebody and they say, I'm lactose intolerant, right? So we know we have good interventions that work within the recovery effort, but we need to make sure, is this for the right person at the right time and in the right setting? Context is essential. And so we talked a lot about how can we be flexible with the interventions that you're offering your clients. We talk about the difference between perfect prolonged exposure and good enough prolonged exposure. So perfect exposure is we're following the protocol. It's very regimented and exact. Good enough exposure is, okay, well, maybe the client is abusing alcohol and we need to be a little bit flexible with how we approach this so that they'll engage in treatment and they won't miss out on that treatment experience. And then just how to create a treatment program that will sustain itself. We don't just want to show up, teach people things, and then it fades as soon as we leave. This is one of those graphics that we walked our students through. So from the planning to the implementation and evaluation phase, different questions. So who are you targeting? Who's your target population, your audience, and how available is this setting that you're in, that you're working at for these services? And so I want to bring this, the workshop we did to life, not just with words, but with images too. So this is our class. We were at a hotel in Lviv for our first workshop, and we chose a brick basement or bunker for logistical reasons, but also just for a felt sense of safety. Lviv is in the west of the country. It's more remote from the conflict, and being in a fortified building just allows them to engage in the learning environment a little bit easier with a felt sense of safety. This is us lecturing, very proud of our team. And to take a minute to celebrate our learners too. This was not an easy experience. The training days were 10 hours long. It was a total of a 50-hour commitment. That's not even including travel time. And there's no flights in Ukraine right now. You have to drive or take train, which can be a significant process if you're coming from the other side of the country. And many of them had families, or they were returning to work immediately after the workshop for another full work week, or they were redeploying immediately after our workshop. And so we picked the right people. They showed up and they gave us everything. And we're very proud of them and grateful to be with them. Between our workshop days, I had the opportunity to walk around Lviv and photograph some of what I saw. Again, speaking to the experience of being there, this was a church in Lviv where they had dozens of paper cranes around the ceiling. They had memorials and shell fragments that were collected, and wall-to-wall photos of people from Lviv that had been lost. And it was a deeply impactful experience being there. So we showed up in October. We had a great workshop. Our students responded positively to it. But like I said, it's not just enough to show up and teach compelling content. We want to make sure that people will develop fluency with implementing the interventions after we're gone. And so we had a variety of activities that we did across the next year. So supervision and prolonged exposure in pharmacology, in research methods. We had a summer school program where we brought 2 students to the United States and taught them research and clinical methods. And then we helped them to develop pilot projects as well that are actively in motion. And so I was involved primarily in the prolonged exposure supervisory piece. Like I said, we're taking it from a conceptual understanding to actually putting it into practice and adapting PE to the populations that they work with. Therapy often has challenges. Let's help our students to navigate those challenges. The goal for a variety of interventions is to have 2 completed training cases. That's what we would commonly think of as being certified in an intervention. That was the goal that I set for my students. This was 1 hour and it was coordinated with my colleague, Brooke Fina, and huge credit to her for her part in managing that experience. And so when we think about what are these common challenges in implementing an intervention or adapting an intervention. So the cultural barriers that we talked about before, the fact that you're not out of harm's way necessarily. People that have had PTSD or traumatic experiences in Ukraine are likely still in those dangerous circumstances. There's the reluctance to engage in treatment. I may know something is wrong, but I might not be ready to address it. And the fact that for a lot of the military personnel that our students teach, they have a 3-week redeployment. So they'll rotate out, they'll get medical services, and then they're going right back to where they came from. And so there's often a reluctance on the part of soldiers to go deep into trauma care because it's just too painful and they feel like they need to be contained before they get redeployed. And there's often concurrent diagnoses too that get in the way. Like I said, alcohol abuse is something that our students are commonly bumping into that cause barriers to treatment. And so how do we adapt? How do we get flexible with our approach? So we focus more on the in vivo exposure element. And so that is it was a list of challenges that we had come up with before. So focusing on that primarily, going slower, trying to take more appointments, doing the imaginal element a bit slower, the retelling, so you're not rushing the client through the story, or very aggressive but appropriate, doing a masked PE model. So what that would look like is you're in therapy every day, 5 days a week, or you're in therapy every day for a 3-hour block. You can do an entire course of treatment in a week, 3 hours a day, 5 days in a row. Very aggressive treatment courses, sometimes necessary. We also, like I said, had the pharmacology and research supervision. And we had our workshop. We were very proud of our workshop that was held in College Station this past summer, where they came for a 4-week program hitting clinical content, research implementation science training, and the development of their pilot projects as well. And so 2 of our students, Dr. Alina and Dr. Dees, Dr. Alina looked at doxazosin and Dr. Dees is looking at written exposure therapy. That was another intervention that we taught them in our second workshop. We'll talk about that in a little while, but I'm very excited to partner with them to help them develop their own science. Like we said, this isn't just us swooping in doing our own research. We want Ukraine to own the projects that are going to come out of this experience. And so Bonus, this was outside of our D43 experience. We were actually contracted by another agency, again, separate from the D43, to provide a similar workshop. And so we had the unexpected opportunity to come to Kyiv in May of this past year. And again, gorgeous city. I was so deeply impressed by what I saw. Again, this is with a different cohort, a very similar training experience. One of the challenges, though, is that translation services were required. And so we had to get creative with how we ran the workshop. We took it a bit slower, and our students were able to adapt and have a positive experience. And I continued to supervise that cohort. So I supervise 2 cohorts right now, the initial one in our first workshop, and then this secondary cohort that we picked up this past year. When I was in Kyiv, again, had the opportunity to visit the Maidan. Again, really deep, moving experience, a flag for everybody that had been lost. And it was staggering, the scale of what had been felt and experienced. Here's some military equipment that had been salvaged and left in the town. And one of the things that I didn't anticipate in this May trip was the fact that there were nightly air raids in Kyiv as well. And I think this is significant because society continues to move and operate despite this happening, and not everyone is in acute danger all the time. But we're building this understanding of what PTSD is. PTSD is a hyperreactivity to threat cues. And I want you to imagine what it would be like for people who have PTSD when they're sensitive to threat, have the experience of these air raids. And so I'm going to show you what that looked like. Oh, did we lose it? Okay. Well, you can hear it, but that was a video that I took outside of our hotel. And so it was dramatic. They would occur twice. One at the other. Did we lose it? There we go. So that's available online if you want to see what that video looked like. But again, people that experience PTSD, there's often a lot of sleep disruption that would happen with those nightly air raids. In this particular event, there were 3 strikes that were hit in Kharkiv, killed 3 people, and 2 children were injured in this attack that night. And this happens every day, all the time. And so we are now into our 2nd year of our workshop. I just got back in October from, again, putting on our 2nd workshop with that cohort. I could not find a photo of all 5 of us together. I don't know what happened, but that's the best I can do. We repeated this workshop in Lviv. We kept the same cohort that we had originally. And I was very lucky that since I was more established on the project, I had a hand in developing the curriculum this time. We know our students had good exposure to PE. We wanted to give them a different experience. And so I had the idea to bring in additionally written exposure therapy, and we touched more heavily on cognitive processing therapy. So now our students have been trained in 3 primary trauma interventions. And we'll talk more in a minute about what these both look like. Again, repeating a similar model. So we want them to have supervision over this coming year, to continue to build their experience in clinical work, to continue to build their research expertise. And the goal is to recruit a new summer school in June of this year, most likely be also in College Station is the plan, giving them a similar experience. We're going to skip that. So I talk about this all the time, but I wanted to walk very quickly through the 3 primary trauma interventions that we've equipped our students with. So prolonged exposure, some primary assumptions, some primary activities, getting really good PTSD assessment and psychoeducation, building a fear hierarchy, executing on that fear hierarchy out of sessions, and then the use of imaginal exposures to process the memory. CPT is a little bit different and it's unique, and I appreciate what it offers. So CPT works to dismantle the traumatic beliefs that people acquired. And we'll see what that looks like. It's a lot of rigid beliefs that keep the PTSD symptoms intact. And it also has 5 modules on trauma themes that result from a traumatic experience. So themes related to safety, trust, power control, esteem, and intimacy, because PTSD disrupts people's ability to engage in these activities. And then written exposure therapy has writing tasks. It purports to resolve PTSD in 5 sessions, which I was very skeptical about, but the more I see it, the more intrigued I am. And so this is CPT. So when we talk about trauma beliefs, what are we referring to? So we think about the idea of stuck points as rigid thinking patterns that prolong the the PTSD symptomology. So things like, because I didn't fight my attacker, the abuse is my fault. I must be on guard at all times. I should be able to protect others all the time. I must control everything that happens to me. Very rigid thinking that causes a lot of trouble for people. And so there's different modules that you work through across a CPT treatment experience, and you're developing skills in each of these categories. And then this is what late stage treatment looks like, is having them complete these worksheets. So you might not be able to see the situation. So what event triggered a the traumatic reaction? And then what stuck point came up within that experience? How intensely do you believe that stuck point in this moment? How can we help you identify your emotions and how strongly you're experiencing your emotions? And then using a Socratic method to begin to question how you're thinking. So are you using all or none thinking? Or is this stuck point a feeling or a fact? Are you ignoring important information? Are you mind reading other people in a way that's just not productive? And then after you walk them through that, you adopt an alternative thought. So let's say the stuck point here is, I must control everything all the time with everyone. And so an alternative competing thought is something like, I can let some things go. I don't have to control everything all the time, maybe certain things. And then you look back and say, okay, now that I've done this, how much do I actually still believe the stuck point? And then have my emotions shifted at all. So you're helping to promote more flexible thinking on the part of the client. And then ideally, they won't have to use these worksheets in the future. It's just learned and automatic. It's just changing the way that they think. And so then we turn towards ridden exposure therapy. And so if you think back to PE, so PE, the way that we process the traumatic memory is a verbal retelling, an active tense. In ridden exposure therapy, the goal is 30 minutes of unbroken writing. And you're writing in the past tense. So I was, we were. And so you give the client a variety of prompts. This is taken from one of the manuals. So in your first writing session, I want you to write about the traumatic event starting at the beginning. For instance, the moment you realize that the event was about to happen. As you describe the event, it's important for you to recall as many details as you remember. What you might write about what you saw, somebody approaching you, what you heard, tire screeching, person threatening you, or what you smell, the blood, burning rubber. Add as many details as you can. This is meant to be an immersive writing activity. And also speak to what thoughts and feelings you had, like, I'm going to die, this can't be happening, or like being frozen with fear in that moment. So again, what's really cool about these 3 interventions is that it just gives more tools in our provider's toolkit, right? Just because we have 3 interventions that work really well, it might not be for everybody. And so what I do with my clients is that I offer all 3 and I say, which one feels right for you? What path in the trauma you lost your ability to choose, you have a choice now what recovery looks like and means. So this is year 2. That's Dr. Nicholson lecturing on assessment. This again was in Lviv for our second workshop this past year. And so we're coming into the close. And so takeaways for me are that assessment is really, really important. If we have good interventions, let's make sure we have the right patients. And then let's use those evidence-based interventions to improve the functioning of our clients. And there's often a synergy between behavioral health strategies and pharmacological strategies for the best outcomes. It's not just enough to show up and have a great 4-day workshop. You need to support and build working relationships with the people that you're training for them to have the best training experience. And also context is incredibly important. This goes back to the idea that we can be a great chef, but we need to make sure we're serving the right people at the right time. So that's the workshop. And what we turn to in the future is, how can we continue to collaborate with Ukrainian institutions? My colleagues who speak Ukrainian are actively involved in that effort to build a research program in Ukraine. I'm also going to be involved, hopefully, in the rollout of a train-the-trainer model. We have great clinicians, and so the goal might be for them to find their own training cohorts, for them to teach PE and then supervise people and also learning PE. And then, like I said, to expand the D43 project to other conflict zones. And so I'm helping to lead that effort. We're working to build an organization called the Global Trauma Recovery Network, the goal being that we can support adults, children and families in terms of overcoming trauma, getting back to a productive and meaningful life, and then just expanding the availability of these interventions that work to the populations that need them. And this is a very new website, so we're still in development, but feel free to take a look at that if that's interesting to you. And also, again, I want to make available the different resources that we have in Austin. And so we have the Trauma Recovery Center here at UT. We treat adults, PTSD, acute stress. We give a variety of interventions. One new one that we haven't already discussed is cognitive behavioral therapy for insomnia, because sleep disruption is so common in these populations. And so I want to spotlight Dr. Sisler as well, who's here. He's leading the TRC research effort here. And so if you have questions for him, he's a great contact in our community. And also spotlighting this cognitive processing therapy study that I'm a researcher on as well, that's coordinated at UT. We're looking for adults, and there's some entry criteria, but the short version is that we are paying you to get free therapy. And so if you or somebody you know would benefit from this treatment, please reach out. I'll put the slide up at the end as well, but we need people, and this is a great opportunity to work with some excellent clinicians. Again, this is not just our team that's involved in this effort. We're pulling expertise from a variety of institutions and universities. Significant thanks to our funding source, to the D43 Fogarty program, and a big thanks to you for your time and attention. If you want to learn more about who I am and what I do and what this project is, you can go to my website. And otherwise, I'll say Dziękuję i spasiba, and I will turn it over to discussion and conversation. Thank you.